It is through the knowledge that healthcare is best received when it is tailored to the individual, and when that individual person is able to make the choice for a treatment option or testing on their own terms. Hi, I'm Judith Maddatu. I'm a nephrologist from Indiana University. Welcome to this webcast from the PKD Foundation on shared decision-making in ADPKD. This is a three-part series where we'll discuss the principles of shared decision-making and its importance in managing PKD. We will review available treatment options, and lastly, we'll go over tips on how to advocate for yourself in collaborating with your healthcare provider through shared decision-making. You've reached part one. Quickly on disclosures, I've worked with Otsuka Pharmaceutical previously in a consultant manner. The materials presented in this webcast are unrelated to my previous work and is not sponsored. So what is shared decision-making? I think the best way to consider it is to kind of step back and consider the timeline of modern medicine. We've come a long way in learning how to diagnose and treat disease. With the passage of time, we are seeing many changes and we are gaining knowledge. The knowledge base of medicine today is different than it was a year ago and vastly different than it was 10 years ago. When it comes to the practice of medicine or the healthcare we receive, we have found that despite all of this acquired knowledge and all of the advancements that we've made, there exists a gap between patient and provider. And the problem is one of dissatisfaction and frustration with healthcare received. There are several factors that come into play. When one sees a healthcare provider, we often rely on their expertise and knowledge, which may be why a lot of decisions are deferred for providers to make. One thing I often hear is, well, if you think it's a good idea, doc. Decisions made by healthcare professionals, we hope, are evidence-based, meaning they come from careful evaluation of what is known about your condition and a standard of care that is backed by studies and acknowledged by others practicing in the field. However, we also know that decisions driven by provider preferences can be affected by location or local norms and their own personal experiences. Such decisions made by healthcare professionals may be at odds with what you are truly comfortable with or would agree to, and they may conflict with your personal goals or lifestyle. Our options are out there for testing and treatment is an important factor in allowing you to take charge of your healthcare. As healthcare providers, we may not be providing support to our patients to be able to make decisions on their own. And this plays into the larger problem of frustration and dissatisfaction, this relationship between patient and provider. The approach of shared decision-making was first developed in the 1980s. The ultimate goal of shared decision-making is to change the focus of medical decision onto the individual patient. It is through the knowledge that healthcare is best received when it is tailored to the individual, and when that individual person is able to make the choice for a treatment option or testing on their own terms. The larger approach of shared decision-making is not just access or collection of knowledge, but forming a rapport between patient and provider and finding ways to navigate or negotiate healthcare. The shared approach from a provider perspective means that we seek your participation. We support your ability to explore and compare treatment options, that we actively consider your values and to understand what is important to you. Your providers should spend time to discuss and evaluate your decisions, and alongside discussions between your provider, you should be able to find a collaborative or consensus decision. Does this approach really work? This is an old article, but I think it demonstrates very well the power behind shared decision-making. This is a study published in 1988 in endocrinology that looked at the use of increasing patient interaction alongside diabetic control, as well as evaluation for patient perspective of their healthcare. The study was done at a university hospital, UCLA. There were two groups, one experimental and one control. Physicians were blind to the study group designations. The initial visit between patient and provider were recorded. Prior to the second visit, the control group was given standardized educational materials developed by physicians and diabetic educators. Researchers reviewed this material and guidelines, such as those for proper care of insulin sites or foot care. The experimental group, on the other hand, prior to the second visit, reviewed the last visit they had with their physician and were asked to identify relevant medical decisions that were expected to arise during their current visit, that second visit. The experimental group was encouraged to reflect on treatment issues that could be affected by his or her lifestyle and preferences. These include things like changing the dose or timing of their diabetic medications or changing their diet. Available options were reviewed with the patient, including benefits, pros and cons. And the researchers discussed negotiation skills with the patient according to a standardized script. Patients were asked to discuss their preferences, their values with their providers and to ask more focused questions of them. What's important to note here is that for the experimental group, the attention is not just on complete information as far as treatment choices, but more of a reflection on their personal experience and what was important to them. This same intervention was done for a third visit. And then after a standard fourth office visit, the following data was obtained. On table 2, you see on the bottom left, we can see that in the experimental group, there was a reduction in A1C, so a marker for glucose control. The lower the A1C means better glucose control. And we can see that between the control and experimental groups, the experimental group did have a reduction, better glucose control compared to the control group. Further, in table 4, we see that patients assigned to the experimental group assessed their health more favorably than did control patients. Other things the authors note was that while the form and substance of physician and patient interactions were altered by this intervention, this didn't really translate to asking more questions necessarily. There is a variability in the response to the intervention, but the overall effect was one of increased interaction between patient and provider. Furthermore, this increased interaction didn't necessarily mean longer visit times. And so they felt that this was an intervention that could be feasibly done within the time of a standard office clinic schedule. Okay. So I know I just said the importance of shared decision-making is this reflection of your personal preferences and values, entailing your healthcare decisions accordingly. The first step would be to identify treatment options available to you so you can have a full and complete reflection. This is a list of online resources about ADPKD, and the first 2 are resources specific to PKD care. This last link is a resource that focuses on chronic kidney disease as a whole. These are helpful to kind of look through and browse. And stay tuned for session 2, where we'll take a bird's eye view of treatment options.